So, good afternoon, everyone. Welcome to Emory's MCI Dementia webinar series. We are so glad that you could join us today. This webinar is a part of our educational series that is sponsored by Georgia MemoryNet, Integrated Memory Care, the Emory Cognitive Neurology Clinic, and the Charlie and Harriet Schaffer Cognitive Empowerment Program. Each month, we have a different topic that relates to cognitive health, dementia care support, and community resources, just to name a few. The previous webinars have been recorded and can be viewed on a link that will be placed in the chat a little bit later in the presentation. I am Alice Cooper Salisbury, one of the licensed clinical social workers in the Cognitive Neurology Clinic. I am joined by my social work colleagues, Ashley Varner in Cognitive Neurology, Jenny Gay in IMC, and Debbie Arnold in CEP. We have a few housekeeping details. This is a webinar format, which means that your cameras are off and mics are muted. We do want you to be able to ask questions of our speaker. So there is a Q&A box where you can submit your questions throughout the presentation. And we will save time at the end for our speaker to answer them. Please note you do not have to wait until the end to submit your questions. And so now I'm going to turn it over to Debbie to introduce our topic and speaker.
Hi, everyone. I am so thrilled to have our speaker, Dee Pfiffer-Reed, today talking to us about driving safety in context of cognitive changes. Dee Pfiffer-Reed is an OTRL MOT, a licensed occupational therapist. This means she earned a Master of Occupational Therapy. She did this in 2019 at Georgia State University. She has worked across the continuum of rehabilitation care at Grady Memorial Hospital. She has experience in acute care, in inpatient and outpatient rehabilitation settings. And she's also worked at the Center for the Visually Impaired here in Atlanta, supporting those with vision loss to maximize independence and quality of life. Her professional interests include senior care, aging in place, and driving rehabilitation, with a focus on helping older adults to remain safe, independent, and engaged in their homes and in their communities. Pfiffer is committed to client-centered care and to evidence-based practice that supports meaningful participation in daily life. And we are just really thrilled to welcome her here.
Thank you for having me. Well, what an illustrious introduction. Every time somebody introduces you, you're like, wait a minute, I do all of those things. Okay. Well, as Debbie said, my name is Pfeiffer. Thank you. My name is Pfeiffer, and I am an occupational therapist. I have worked specifically in the area of driving rehabilitation since 2022. And it is a pleasure and a joy to serve in this capacity. As you might know, occupational therapy, we're really concerned with quality of life, people having their best quality of life, being able to engage in the activities that you need to do and want to do to live an enjoyable life. And driving is the ultimate in independence. Oftentimes, when people are faced with losing that independence. It can be a very emotional thing, but I like to say we stand in the gap for them and help them to figure out their situations. So, as Debbie said, I work for Freedom and Mobility. We do driver training and evaluations. We are certified driving rehabilitation specialists. And that essentially just means that we know how to work with a lot of different people. Uh-oh, why is it not progressing? Okay. We serve older drivers. I will say about 60–70% of our clientele are older drivers. They come to us for a myriad of reasons, everything from decreased mobility or impaired functional mobility, low vision, and then, of course, the most common reason we will see older adults is due to cognitive impairment. Anything from mild cognitive impairment to Alzheimer's, um, different types of neurodegenerative diseases, so Parkinson's, you name it. And if it causes a cognitive impairment, we see them for some reason or another. We work with people with physical disabilities as well. So sometimes I see my older drivers because they've just had an amputation, a below the knee amputation, or something like that. And then we also work with people with learning impairments or cognitive learning disabilities. Okay, so challenges that our older drivers face, and this is irregardless of cognitive impairment or not, but just as we age, things tend to slow down. So a lot of older drivers have issues with like slower reaction times. Um, their vision and their hearing can be negatively impacted. Reduce flexibility and strength. Again, that functional mobility piece I spoke to earlier. Increased medication use, and all the contraindications that come with that. And then, of course, those cognitive changes that can really impact their judgment and their level of awareness. And I forgot to say, I am very conversational in how I present. I keep the slides just to the bullets, and so I can expand as you guys need me to. So if you don't want to wait to the end to ask questions, feel free to jump in. I'm not gonna stop you. So we often have to work with families and with providers on, okay, when should somebody sort of consider seeing a driving rehabilitation specialist? When should we consider talking to them or having the conversation around their license and their driving abilities and their skills and what you're noticing? So we always tell families and employees, when you see that their driving skills have deteriorated, like if you're expressing concerns, if friends are expressing concerns, if you know that you have some concerns, it's a good time to start looking at it then. If if you notice that they've gotten lost on a familiar route, or if I just had a gentleman who was going around the corner to his Rotary meeting and showed up an hour and a half later, and that was because he got lost. It's actually just a 5-minute drive around the block. So if you notice that people are getting lost on those unfamiliar routes, again, a good time to consider seeing us. Unexplained dents, scratches, or vehicle damage. Um, this is a big one. Hitting garage doors. The pole at the fast food restaurant is a really popular one for people to want to take out. Mailboxes, curbs, anything that you're noticing that this damage to the vehicle that they can't explain might be time to seek us out. If you notice they're requiring assistance with IADLs, so your IADLs are those instrumental activities of daily living. They require a much higher order thinking. So driving is the highest. Driving combines everything together. So driving is your highest IADL. But another one is medication management, financial management. If they are able to manage their medications, if they aren't able to manage their finances, I strongly suspect they're going to have some issues behind the wheel. Okay. If you've noticed an increase in falls, so something could be going on again cognitively, something could be going on physically, but any increase of falls usually signifies some type of change that's occurred. And then, if you notice they're frequently losing items, repeating themselves, have poor short-term memory or working memory, as we sometimes call it, once again, great time to talk about driving. And then the other reason, the last DMV medical review. So I have some people who present to me, and it's because the Georgia Department of Driving Services has sent them this beautiful letter that says you need to get evaluated to see if you're fit for driving. And if you don't do this within 30 days, we're just going to revoke your license or suspend your license until you provide proof that you are a suitable candidate to drive. This happens when um, individuals are pulled over. So the police might note that they might seem out of sorts. They might not be as well kept as they should be. They might not be communicating coherently, or they might be saying things that don't match up with what the situation is. So a lot of times the police will initiate this medical review. Sometimes it comes from the physicians themselves. The physician sends something to the Department of Driver to the Department of Driver Services that says this individual needs to be, looked at. And so then the DDS will send you the letter. And then other times it comes from family members. And a lot of people don't know this, but you can report your loved one. If you have concerns, you can report them to the Department of Driver Services, and they will send out this lovely little letter. And I'm absolutely being facetious in calling it lovely. I had one lady describe it as hate mail. She didn't understand why they were sending her hate mail. So, so yeah, families can also request, and you as providers can request for a DMV medical review as well. And they are anonymous. And we'll talk a little bit more about that in a little bit. So, what happens? What can people expect when they come for an evaluation? And what are we looking for? What am I interested in as an occupational therapist? So, a few things we'll do. The first part is your clinical evaluation, and then we will follow that with a behind the wheel evaluation where they actually get to get out on the road and show me what they have. Okay. For the clinical evaluation, obviously, I need the past medical history. I need to understand what illnesses, what conditions, what comorbidities you may have, and knowing all of that drives all of the other questions that I have to ask. So if you have, mild cognitive impairment, clearly I'm going to be asking just about your routine, and I'm going to be doubling back on things just to make sure I'm getting consistency in my answers. And I have to kind of synthesize all of this information with everything you have going on. So you have the cognitive impairment, and now you have diabetes, and now you have these things. So I have to synthesize all of that information to make sure that I am, one, presenting the information in a way in which you can receive it, but also that I am accounting for everything that might need to be accounted for in the driving environment. I try to get a good understanding of driving history. If you have put any restrictions on yourself, say you no longer drive at night or you no longer drive on the highway. I want to know how long you've been driving. If you've had any recent accidents, I'm going to ask about any unexplained dents and scratches in your car. I'm going to ask if you've ever become lost. Um, or if you have to rely on someone to give you cues when you're driving. I want to know the distance you normally drive, the time of day, if you're driving daily, if it's just a couple of times a week. All of these things help us to make a informed decision and recommendation. And we'll talk a little bit about that in a few more slides. So the primary things that I'm assessing clinically, I'm assessing motor, hearing, vision, and cognition. So from a motor component, I want to make sure you have proper strength to operate your primary controls. I want to make sure that they have um, proper range of motion in which they can turn and look and bend and do all the different things they need to do to access the driving environment. I want to make sure that they demonstrate good balance, that they demonstrate a good reaction times, that they demonstrate really good coordination. Um, when I have people come with cognitive impairments, dementia, mild cognitive impairments, you name it, they always try to talk to me a lot because I think they're kind of trying to prove that, I am okay and I can do this and I've been driving for decades. And while all of that is true, there are always some telltale signs that let me know that I'm dealing with some type of cognitive impairment. From a motor perspective, one of those things is coordination. A lot of people with cognitive impairment have impaired coordination. So we do this assessment where we're looking at their rapid alternating movements. And a lot of times people with cognitive impairments, they're not able to do that in a coordinated effort. One hand might be able to, but they might not be able to do, both hands together. So that impaired coordination is always a telltale sign for me. And why that matters in driving is because you have to cross your body a lot, right? You have to be able to move hand over hand if you want to do a proper turn at times, or transitioning from the gas and the brake. That requires coordination. So, obviously, I'm going to be assessing that. Hearing is pretty straightforward. If I'm having to constantly yell and repeat to myself, do you wear your hearing aids or your hearing aids not functional? Obviously, all of those things will kind of let me know what I need to do. And then I look at vision. And vision is another one of those, I call it like the sleeper skills. So most people just think about visual acuity, which, yes, I care about visual acuity. Georgia requires you to have at least 20/60 in one eye, right? I care about how well you see. But more importantly, I care about your oculomotor skills. So oculomotor skills is how your eyes move. Can they move in a smooth manner? Can they move in a coordinated manner? And can they move in all the different ways in which we need them to move? This is another big impairment that happens for people who have cognitive impairments. Oculomotor skills are usually impacted, and that's generally because of the posterior of the brain is impacted, and that's where like that motor processing sort of comes into play. And so we see impaired saccades, so those rapid eye movements. Oftentimes my people with dementia, their eyes will just kind of get stuck and fixated, and that's because of like poor inhibition. They can't stop it, but also then there's the working memory part of, do I remember actually what I'm supposed to be doing for this assessment? So we see a lot of impaired rapid eye movements. I see a lot of impaired, what we call visual attention. So, can you maintain your attention to point A while being presented with a different stimuli? Can you keep track of what I'm asking you to keep track of while being presented with other pieces of information? And oftentimes that is very hard for those who have cognitive impairments. It's incredibly hard. Another oculomotor skill that I pay very close attention to is something called vestibulo-ocular reflex. Essentially, it's your ability to separate your head and your eye movements, right? Can you look straight ahead and keep your eyes fixed on that point while turning your head? This is again another skill that's usually impaired for those with with cognitive impairment. Granted, it's usually a little bit more severe when you have a vestibulo-ocular reflex deficit. But it's a really important skill because if you can't separate your head and your eye movements, wherever your head goes, your eyes go, and that means that's where your car will go. So if you ever see people who just like walk aimlessly, they might have some difficulty separating their head and eye movements, and their head and eyes lead everything else. Lead their body, it'll lead your car, it'll take you wherever you want to be or wherever you really don't want to be. The other part of vision, and it's really more of a cognitive skill, is vision perception. This is another telltale sign that usually gives away my cognitive impairment individuals. Vision perception is incredibly important. Not only does it help us to discriminate when we're looking at things to pick out important information, but it's responsible for helping us understand where we are in space as it relates to other objects or other people. So, to translate that to driving or to transfer that to driving, vision perception helps you understand stopping distance, right? Make sure you don't get too close because you understand where that car is, you understand where you are. It helps you gauge timing. So, do I have enough time to complete that turn before this oncoming car gets too close? It helps you to not turn too wide, not turn too narrow, maintain a center lane position as opposed to drifting left and right or constantly being over the right side of the onto the shoulder. So vision perception is something that's incredibly important, and it's probably one of my most failed tests in people with cognitive impairment. We use a subset of the MVPT3, and it has been shown that people who miss more than four on that specific subtest, they're two times more likely to be involved in a motor vehicle accident. So vision perception is incredibly, incredibly important. And then we segue down into the cognitive skills assessment. Okay. I'm looking at how much information can you process? How quickly can you process that information? What types of information can you process? Can you switch back and forth between two types of information or that multitasking or divided attention, right? I'm looking at working memory, attention, concentration, things of that nature. Um, we use several standardized assessments. Again, the MVPT3 is the one we use for that vision perception, and then we'll do trail making A and B. Trail making B, if you're not familiar, is the one where you have to switch between two types of information. So it's numbers and letters, and you're connecting those in sequential orders, alternating number, letter, number, letter. Trails B has been shown to correlate to behind the wheel performance. There's a direct correlation. So people who do poorly on Trails B generally will do poorly behind the wheel as well. And again, they love to talk to me. They love to make sure that I know that they know what's going on. But when we are 30 seconds in and we've only connected one in A and we've forgotten the instructions and I can only repeat them so many times, we start to see those discrepancies, the things that they just honestly can't help. And then we'll do mini cognitive assessment. We might do like the short blast or um, slums or one of those. We'll also do symbol digits modality, again, alternating the types of information that you're trying to process, while also looking at visual scanning, visual motor ability, things of that nature. If they do have a motor concern, like if I have a person come in with Parkinson's, there are ones that I give that are oral where we can take the motor component out, because I always want to make sure that I'm assessing for the right thing. I don't want to get a result that's not due to their ability, but more so that's due to something that they actually couldn't perform anyways, that has nothing to do with their cognitive capacity. Obviously cognition is everything. Aside from the standardized assessments, clearly I'm looking at my clinical observations are also telling me what I need to know. How often am I having to repeat my instructions? How simple am I having to make my instructions? Do I have to take a three-step and break it down into a one-step, or do I have to prompt you for each step for you to understand what's happening? Am I having to go slower, providing more time for you to give an answer because maybe there's some delayed processing or decreased initiation ability on their part. But the clinical observations are very important as well. Did you need help reporting your medical information? Am I having to constantly like look over to your loved one to just verify that what's being said is actually true and accurate of your situation? I try not to count it against them when they can't fully report the medical history. It's come to my attention that people think that because they take medications for something, they no longer have it. So there's a lot of underreporting. And then when I get to the medication part, they give me this laundry list of medications. And I'm like, okay, so you have high cholesterol, um, hypothyroidism, like just by looking at the medications. And they're like, yeah, I take medications for it. I don't have it anymore. And I'm like, okay, that's not exactly how that works, but I'm going to work with you today. So I try to approach it in a way that's very light and in a way that is very disarming because again, we are talking about driving. We are talking about potentially limiting their ability to get around and to enjoy something that was once considered a rite of passage and that's now considered an absolute must, a necessity. And so for some people, when that is potentially going to be taken away, it can create a lot of anxiety for them. So I really try to put everybody at ease and let them know that I'm here to help you do your best and be your best. And I'm going to give you every opportunity to show me what you have. If I have any concerns around the clinical evaluation, we go over those at the end because I might need to give some strategies for when we get behind the wheel. So we will definitely cover those at the end. Before I move on to talk about the evaluation, one of the biggest cognitive concerns that I have, or the red flags for me, you can have some poor memory, you can have, you know, um, you can forget and repeat yourself a couple times. You can need a couple more minutes to respond to a question, to respond appropriately to a question. The biggest red flag for me is oftentimes that lack of awareness. When you have a lack of awareness into your capabilities, when you don't have proper insight into your deficits, you are less likely to control for them. So you think that you can perform at the same level you've been performing, and that might not be the case, but you're not open to doing it differently. So that's one of the biggest red flags for me. And when it comes time to making recommendations, and I'll cover a little bit again more about the recommendations towards the end. So we did the clinical. Now we need to go out and we need to actually go behind the wheel and see what you have. So here I'm looking at those operational, strategic, tactical skills in the car. Okay. Do you make smooth turns? Can you keep a good speed? Do you give people enough stopping distance, etc.? But my primary thing that I am looking for behind the wheel, because again, I am not the DMV, right? I'm not really concerned about the 10 and the 2. People come to me and they have been driving for my person 2 days ago, they've been driving for 66 years, and you develop a lot of habits over 66 years. So I always tell people, you drive how you drive. I'm not looking at that. I am simply looking for good decision making. I'm looking for good judgment. I am looking for you to be safe. I'm looking for you to be able to properly scan the driving environment and make the appropriate decisions based off of what it is you see and what it is that you are processing. So that's my primary concern behind the wheel. Okay. Now, once we do all of that, we come back, we talk about everything, and then we will discuss recommendations. Okay. So there's a few things. One, I could not have any concerns at all. And I have people who come in on the mild cognitive impairment side of it more so than anything, where I'm like, okay, I don't have a concern right now. Come back and see me if there's a significant decline in your cognitive abilities, cognitive, physical, whatever abilities. But then there are times where I'm like, maybe we need to do something a little different. So there are levels to driving restrictions before we get to all out driving retirement, right? So we can say you're fine to drive, just maybe limited to familiar areas only, right? Or you're fine to drive, but no nighttime driving. Avoid the highway, avoid peak hours, right? And the reason we give those is that each of these, driving at night, driving on the highway, they add an extra layer of complexity. When you're driving on the highway, things are happening incredibly fast. So if it takes you a little bit longer to process what's really happening around you, that might not be the most successful environment for you to be in. Same thing with driving during peak hours. It's very taxing. It causes a lot of tension and stress just for anybody who doesn't have a cognitive impairment. So if you add on that layer of cognitive impairment, is that likely to frustrate you? Is it likely to, will the stress exacerbate any of your other symptoms? Especially like that forgetfulness and that short-term memory component. Um, Sorry about that. And so, And so, we have to look at those things. Driving at night, again, just one more thing to process, one more thing that can keep us from being able to pay attention to what we need to pay attention to. Okay. If none of those are going to work or a combination of those isn't enough, then at that time we will talk about driving cessation or driving retirement. Um, it is very hard to broach. I say it's the hardest and the easiest part of my job. It's hard because I understand what they're losing. As a person who I get rid of stress by driving. I know that doesn't seem like a cool thing to do in Atlanta, but I enjoy driving as a stress reliever, and so I can only imagine what it's like to not be able to do that. And so it's the hardest part of my job from that perspective, but it's the easiest part of my job because I'm tasked with keeping you safe. I'm tasked with keeping other people on the road safe. And so if you not driving is going to keep you safe, it's going to get everybody else on the road back home to their loved ones, then it's a decision that I am most happy to make. I also live by a creed that says my license is my livelihood and I can't put it on the line for anybody. So I have to attest to every decision I make. You can't slide me a 20, which somebody just tried to slide me a 20 last week. You can't slide me a 20 and get me to change my mind. My license, my OT degree was very expensive. It cost me more than $20 and I'm still paying for it. So I don't put my license on the line for anyone. So I have to be very confident when I make these recommendations because in essence it really can be life or death. Um, and then sometimes people might need like a little bit more therapy. So they might need vision rehabilitation to work on those ocular motor skills. They might need OT, they might need PT, they might need speech from a cognitive perspective. And those things might help them get to a place where they can drive again or where they can drive without restrictions or um, or what have you. Um, but yeah, so the recommendations, it's always case by case. I do take into consideration family, and I always explain that I am seeing them but for one moment in time today. Today, they showed up as a rock star, right? They blew me out of the water on their clinical evaluation. They drove like a dream in the middle of traffic. And so I'm like, this person looks really good. But if you then tell me that they've been lost 3 times and you had to call the police one of those times, or that they or that they're just requiring a lot of help from you with just basic ADLs, I have to listen to that. And I'm going to give a lot of weight to that because families and caseworkers, you guys see them way more than what I'm going to see them. So you have a better understanding of who they are as an individual, how they perform as a driver. So a lot of weight goes into what the family and caregivers are saying about their driving ability. My favorite one is when they tell me, "Oh, I don't drive with them, and I don't they can't drive my kids anymore either." And that's my clue. Like, if you don't want to drive with them, I don't want to drive next to them. So we are setting ourselves up to say that this might not be the task or the activity for us. So that's what those recommendations are. We currently do not report directly to the DMV. So if I make a recommendation, particularly for driving cessation, we currently do not report to DDS. That is about to change. Um, Again, I just feel like since we're the ones making the recommendations, we should be communicating this information directly to DDS. In the past, we have just sent it back to the physicians because usually people are coming from a physician's order, or because a doctor said, "Hey, we're concerned about this. Let me send you here." Um, so we send it back to the physician, and they have the capacity to go ahead and say, "Hey, okay, you're not legal to drive," or we can submit this to DDS, and they're gonna suspend your license or revoke your license. But we will be doing that going forward. I think we start in March, so we will be doing that going forward. Um, we try to offer various resources if driving retirement is the solution. A lot of counties have transportation that can assist seniors with getting to and from their appointments, and then you have Uber Health. Um, and then of course activating your network, your family, your friends, things of that nature. Even if you have a home health aide, sometimes they're willing to drive, or whatnot. And there are some Medicaid programs that'll pay for stuff like that as well. So I try to kind of hook them up with their council on aging or their senior services, for their particular county, to give them some options as far as driving, alternatives, and alternate driving plans are concerned. So, hmm, let's see. Okay, so we try to counsel families on how to have this conversation. Families communicating anything sometimes just everything gets lost in translation. I don't know if there's a great way for families to communicate or not, but we try to encourage everybody to approach the situation with respect, and definitely don't do it right at the instance of something having occurred, right? Like when they are already upset because maybe they did just take out the fast food pole or they did just clip the garage door. You're not going to get the level of feedback and input that you desire from them when they've already made a mistake and they know they've made a mistake. Um, Approach it at a later time, address some specific, things. Hey, when we were at Chick-fil-A, I saw that, you almost took out the red pole. So, I'm just a little concerned and I want to make sure you are safe. Again, we talk about alternative transportation solutions, and I always encourage families, get their care team involved, get the doctor involved. And when I am my grandmother's primary caretaker, if you guys missed that at the beginning part of this, and every doctor we went to, I just had a little aside with them and just told them, like, this is something we want to have happen. If you can bring that up for her, just so she's getting it from multiple places, even if that doctor doesn't have anything to do with it. I mean, I told the dentist, I told the her primary, I told the cardiologist, whoever I was going to go see, I told them that this is what we're trying to get her to do. Can you bring this up? It had nothing to do with what they were actually treating her for, but they were more than willing to just put a plug in their ear for me, and we were able to convince her to choose the safe option. So again, we talk about ride sharing. If you have public transportation, those community senior transportation services, and then if walking is feasible. I know for most of us it is not, but if walking is feasible, you can do that. The last, and what this QR code is for, is it is a link to the driving review form. So earlier I talked a little bit about the medical review process for the state of Georgia. Again, families, case managers, providers, anybody can submit. It is of non anonymous. You do have to have some specific information, their name, birthday, things of that nature, but you can report your loved one anonymously, and they will get that letter, that hate mail, as my patient called it. The hate mail will come to them, and you can say it's out of your hands. Hey, this happened. We've got to take you to the doctor so that they can, get us to the driving rehabilitation specialist, or you can actually come directly to us as well. You don't have to have an order, but that document will start the process of really forcing the issue, and it takes the family out of being the bad guy saying, hey, I can't do this, I can't, they won't let me do this, they won't let me do that. So it's definitely a strategy that I suggest, especially when you have some serious concerns and they just will not give up their keys. So, and then what we do to get started, I always, again, I need the present history of what they're currently going through. Um, if they have low vision issues, then I need to have an eye report from their ophthalmologist or their optometrist. Any type of cognitive impairment, I like to have some type of neuropsych screening or evaluation. Not everybody has always completed that when they've come to see me, or theirs might be really old. I just try to have as much information as I can, or explanation of what's being experienced as much information as I can. Naturally, I need a list of current medications. And then if they come because of they have a DMV medical review, then I have them bring that letter as well. So here's my information and information to our website. And at this time, I would love for you guys to ask me some questions.
Pfeiffer, thank you so much. That was really, really fantastic. It was
Of
it was
course.
very, very thorough and I think opens the black box of when we say we recommend a driving evaluation, what that, what we're recommending.
Hmm.
There are a couple of questions in the Q&A section.
Okay.
One is, are these recommendations based on an honor system? How do you enforce the recommendations? And I think you
Okay.
kind of alluded, but can you go into it in more detail?
Yes, they are essentially based on the honor system. The driving cessation, that is going to get sent to the DMV by your doctor, or at this point, it's going to be sent by us. Anytime that we recommend someone stop driving, that's going to be sent to DDS by us. So, yes, you can look forward to your license being revoked, and you can now present yourself to DDS so you can take a brand new picture for your ID. So that part will be reported. The other portions where we're saying, okay, driving is limited to familiar areas only, must use a GPS, right? That is an honor system. However, I try to tell people that if you get in an accident and that family raises any concerns about your capacity for driving, if the police have any sneaking suspicion, if anything comes up at all, and they find out that it was recommended that you didn't drive in the condition in which you were driving when you hit their loved one, the liability is on you. And when I get some pushback on that because they're like, well, I'll just do what I'm like, and guess what? You can absolutely do that. But let's just start talking about your estate and your children's inheritance because that's what you are putting at risk. And I have gone to court once to defend what I wrote in somebody's evaluation, and it did not end favorably for my client. It won't end favorably for you if you were deemed to be at fault. And so that's where, you can decide if you want to take that risk or not. But this is also where, for me, when I'm working with people with cognitive impairment specifically, when they are showing me that they don't really believe that they have the issues that we are saying they have, that they are presenting with these deficits. I actually had a lady last week who, after we drove, I said, okay, you're okay. You can continue to drive mild cognitive impairment. Um, but she kept fighting me on the fact that I said she couldn't drive at night. And I'm like, right now, you don't have permission to drive at all. So you would think that somebody telling you, yay, you can drive, just avoid driving at night, which is something that she told me she had already avoided. So you would think that me saying that would be music to your ears. I'm giving you the ability to drive again. I just want you to avoid driving at night. We went back and forth about 30 minutes, and that told me you're going to go out there, you're going to do whatever you want to do. And I now know that. And now that I know that, I can't unknow it, right? And so the recommendation became driving cessation based off of that 30 minutes of back and forth. She's like, well, just tell me why I have to. And I was like, I'm going to tell you why. And just so you know, this is actually my fourth time telling you why, right? This is what I'm talking about. Like, and so it went from a no driving at night to you can't drive at all because I don't trust you. And again, I have to be able to sleep at night. I have to be able to say, okay, I did right by you at that point in time. If I have to go to court and I tell them, yeah, the last 30 minutes we were arguing back and forth about why we even needed these restrictions, they're going to say to me, something in you should have known that this was a potential possibility. So it was a very interesting time. I did not see it ending how it ended. It was very unfortunate, but that lack of awareness, lack of insight, it trumps almost everything.
Well, that speaks, thank you, Pfeiffer, and that I think is a partial answer to the next question, but I'll go ahead and read this. If an individual receives a report that reflects concerns, what happens then? You did cover that. If they have been diagnosed, for example, with early Alzheimer's, aren't they at greater risk of being found to be at fault if they get into an accident, even if they are not at fault? If you advise person not to drive at night, what if they get into an accident driving at night but are not at fault? Is there a test result that means a person should not be driving at all? What happens then?
So there's not one particular test result that says, okay, you should not drive. It's the amalgamation of everything that we are seeing. It's the synthesization of all of that information that I'm processing from the moment I see you get out of your car until the moment you back the car back into its parking spot for me. So there's not one specific test. There are certain markers, like again, I said that trails B. Trails B is the performance on Trails B correlates to performance behind the wheel. Vision perception, again, people with vision perception impairments, more likely, the research shows that they're more likely to have an accident. So when I have you hitting on all of those and it's not trending right, um, we are definitely working our way into either some restrictions or to driving retirement, usually speaking. Um, Again, I think I talked a little bit about if people drive after the recommendation, that is something that they absolutely positively can do, especially if their loved ones are afraid to take their keys or unplug the battery to the car, um, which is something I've had to have people do as well. But if they do that, then that there is a potential for them to be liable. Even in the instance where they'll be under more scrutiny, I won't say that the police are automatically going to say, "Oh, you have this," and therefore it probably was your fault. But you are going to be under more scrutiny, even in accidents that aren't your fault. You can still be called to account for what's already in your medical record, just to be clear.
I believe that we have, in fact, I know that we have seen situations where somebody was in an accident that wasn't their fault, but they were still called to account and still lost in court because they were driving without having clearance. So even though the accident wasn't their fault, it was the trigger for
it,
the
yeah.
whole investigation. And
Yeah.
they, as you mentioned, they in that situation they lost big. There's one more. I may have missed this because I came on a bit later, but after an initial assessment, is there a yearly reassessment recommendation, and who initiates that exam?
Yes. So we all of our reports expire within a year or the year. So you come to see me on February 6th, that report will be good from the 6th of 2026 to the 5th of 2000, February 5th of 2027. So they are good for a year. We explicitly state now that if you have any type of neurodegenerative disease, any type of degenerative like eye conditions, then you are definitely required to come back and do that. There's also a disclaimer that should you notice cognitive changes before that time frame, that you should present back. So right now, we will kind of like your dentist or whomever, like a month or two before it's set to expire, we reach out and say, hey, this is what's coming up. And we do have a lot of people who present back to come and do their assessment. I had a gentleman who 2 years ago, I evaluated him. We kept him on the we kept him on the road. He was a very tricky person because he was dealing with some delirium, hospital-induced delirium at the time. So you're trying to plan for all of that. But now he actually does have alcohol-induced dementia. And so we had to change the recommendation. So he came back to me for 3 years. And this last year, I had to tell him it was time to, to give up the keys. But yes, we do have them come back. And again, it's not anything that we can force, but the understanding is that this report was good for this amount of time. You have allowed it to lapse. Doesn't really change what the report said. The onus is still on you to come and make sure you're still good to drive. So once again, if you have an accident, this still plays a part. Yeah.
Thank you. Thank you for that. I
Oh, and
don't
on the inverse, I just had a gentleman who when I saw him the first time, I put in all the restrictions, everything. And then I just saw him last week as well, and he doesn't have any restrictions. So
that's a great story. I don't see any other questions in the Q&A. So if folks have any last questions, please do put them in.
the one here that's about insurance, is it self-pay if it's covered by insurance if referred by medical doctor? So it is self-pay. One of the exceptions, VA. The VA will pay for driving evaluations. Otherwise, yes, it is self-pay. There are some organizations too that might give, money for you to do a driving evaluation, but VA is the only consistent payer that I am aware of.
So as a follow-up to that, Pfeiffer, will they pay other than, I mean, they have driving evaluations at the VA that are covered, but will they pay outside providers as well?
Oh,
That's good to know.
yeah, they will.
Really good to know. Any last questions? All right. Thank you again, Pfeiffer. This was really fantastic. It's really important information, and it's a loaded topic. I mean, it's really driving is such a huge part of who we are and our independence, and especially in Atlanta,
Yes.
we can provide all the resources that are there, but sometimes it is super challenging
Yeah.
because they're not enough. So
Yes,
thank you.
they aren't, unfortunately.
Yeah. So thank you very much for being here, and thanks to
Thank
all of our
you.
attendees. Glad to I hope to see everyone again. Oh, I see a couple of more Q&As. Two more pop up. Oh, what happens if you don't take the driving evaluation, but it is recommended?
Same thing.
If
If your doctor has put that in the chart that they have driving concerns and they have recommended you for a driving evaluation, it's the same adage. If it's documented anywhere that there is a concern in this area, it's going to create additional liability for you. So try to encourage them to take the evaluation. Or if they don't want to take the evaluation, like I said, scan that code or go to the DMV, put in DMV medical review process. It'll take you to the form that you need, and you can let DDS do the dirty work for you. Because DDS, they were required to act with DDS. If they don't act with DDS, then they get it automatically revoked in 30 days. So you decide.
most most medical providers will make a report for a medical review. If you choose not to follow through on the driving eval, most medical providers are gonna report, and then you will get that letter. I know that's typically what we do here at Emory. Thank you for the session. Alice, thank you for putting into the chat the link if people are interested in other Dementia webinar series entries, if you will, that we've had over the last 4 years now. You can take a look at them at this link, bit.ly dementia videos, and that will take you to a YouTube link that has all of them there, as well as the related links on the CEP website. So really pleased to have everyone here today, and we look forward to seeing you again next month in March. Thanks.
Thank you. Thank you for having me, guys.
Bye for thank you.